Welcome to Tuned In with Mike Johnson, a public service of Mount Wilson FM Broadcasters and Global Jazz Incorporated. Now, here's Mike.
And a very good Sunday morning to you. My name is Mike Johnson, and this is Tuned In on Go Country 105, KJazz 88.1, and K-Mozart 1260 AM. My guest this morning is Dr. Juan Carlos Alejos. He's a physician at UCLA, and our topic this morning is pulmonary hypertension. Doctor, good morning.
Good morning.
Thanks for being with us on this Sunday morning. So just to initiate everybody, what is pulmonary hypertension?
I mean, pulmonary hypertension essentially is an elevated pressure in the lungs. I mean, the heart and the body have two different systems, one being the blood flow that goes to the lungs to pick up oxygen, and the other being the blood flow that goes to the body to deliver the oxygen, to deliver the blood and oxygen to all your vital organs. Mm-hmm. And normally the blood pressure up to your body size, because there's much more area to cover and much more distance to cover, is usually about 3 to 4 times the pressure that you find in your lungs. In some cases, for a multiple number of causes, you can develop high blood pressures in your lungs that basically come equal to or even exceed the blood pressure that goes to your body, and causes what's called pulmonary hypertension.
You know, for some folks who may suffer already from high blood pressure and they're hearing this term, there is a difference, though, per se, between high blood pressure and hypertension, true?
Absolutely. Between high blood pressure and pulmonary hypertension, yes. They're totally separate. You can have one and easily have one and not have the other.
Now, what folks are there demographics to show how people are more likely to acquire PH? Is it based upon ethnic background, or is it gender specific, or who gets it? It's
actually there's a variety of causes. So each cause can have its own specific specific target group. For instance, you can develop pulmonary hypertension if you have lupus, if you have kind of rheumatoid arthritis, if you have scleroderma. That population can develop pulmonary hypertension. You can also develop pulmonary hypertension if you have portal hypertension, which is a type of a problem that you can develop in your liver. You can develop pulmonary hypertension if you have an associated heart defect, such as, a ventricular septal defect, a common communication that can be seen in the heart. If it's large enough and left untreated, can lead to the development of pulmonary hypertension. You can also have it if you have sickle cell anemia. The biggest group, unfortunately, falls into what we call idiopathic, which means we don't really know what causes it, but it can be familial. It can run in families. So really, there's no specific target group or population. It's just something that, unfortunately, is associated with many conditions, but can be quite devastating in its own right.
And that was kind of where I was going. I was thinking, if your parents have it, if your grandparents have it, is it likely to be passed down the generations?
It definitely can be. And it's something that once it's diagnosed, it needs to be, the subsequent generations need to be evaluated to make sure that they don't have any signs of pulmonary hypertension.
Now, pulmonary hypertension is abnormally high blood pressure in the arteries of the lungs, and it makes the right side of the heart work harder than normal.
Correct.
A silly question, possibly, but why the right side, not the left?
Well, the right side of the heart is the part of the heart that's responsible for pumping blood to your lungs. The left side pumps blood to your body, and actually, because it's normally, as I said, your pressures in your left side are much higher. Your left side is actually much stronger. So your right side of your heart is not designed to do this kind of hard work. And so actually can create or lead to a bigger problem or cause a bigger problem if they develop pulmonary hypertension.
When people come in to see you, and again, this is Dr. Juan Carlos Alejos. He's a physician at UCLA Medical Center on tuned in here on Go Country 105. When people come in to see you, do people immediately know they have pulmonary hypertension, or do people have these symptoms but they really can't pinpoint what's wrong with them?
Typically the latter. I mean, typically, and actually this kind of leads to the biggest point I think that needs to be made is, pulmonary hypertension is a very difficult diagnosis to make.
Mm-hmm.
It can kind of masquerade as many other conditions. But I mean, the most important thing, that leads to a positive or improved prognosis is early diagnosis and early referral. But I mean, many things can, for instance, fainting, chest pain, shortness of breath, inability to exercise. In children, which is I see both children and adults, but in children, many of the kids who present to us with it are they just want to be carried. And it gets missed for years because the parents, just feel as if, well, this is, my child just doesn't like to walk. He's kind of lazy. He wants to be carried. Until somebody finally, kind of looks a little bit further. But, so it's really, very vague general symptoms. And and it's definitely not something that a physician would look for initially. If you come in with being fatigued, pulmonary hypertension should not be at the top of your list of potential diagnoses.
Mm-hmm.
However, the important thing is it should be on your list. And if other things that are more common, leading to fatigue or exercise intolerance or chest pain, are ruled out, and you still have no cause to explain it, it should be entertained as a possible diagnosis.
Has PH become more prevalent in society in the last 20 years or so?
I think so. I think it's become much more, for a couple of different reasons. One, it's become much more recognized. So I think the diagnosis is being made more readily because people realize it's a true entity. And secondly, I think that other conditions that can cause pulmonary hypertension, which in the past were fatal long before developing pulmonary hypertension, are now something that we can actually treat and can lead to, so actually now as we treat them, they live longer, and as a result, then they are diagnosed with pulmonary hypertension when in the past they didn't survive to that age.
So now, in general, you've laid out a few examples of conditions that people may be suffering from. Is there a simple, a gotcha moment, if you will, that you have the disease, or is it really through testing that's determined?
Really, it's the testing that makes a diagnosis. There are some standard non-invasive tests, a variety of different tests that can lead to the diagnosis of pulmonary hypertension. But it's something that is slow to evolve in evolution, and as it does, then that you get to the point when you make the diagnosis, when it becomes severe enough that somebody actually does the test to make the diagnosis.
People who live with it every day, how many people are coping with PH on a daily basis in America?
It's very low in incidence. It can be 1 in a million.
Okay.
It can be, but again, it depends on the different conditions that are involved.
Mm-hmm.
I think the population is growing, again, more because of recognition of the condition. So I think the true numbers are very difficult to really put your finger on, because I think a lot of people out there are still misdiagnosed or not carrying the proper diagnosis.
As far as day-to-day, what you deal with there at UCLA, obviously, as a pediatric cardiologist, you're obviously seeing children every day. Tell me a story about a child, and obviously you won't have to name a name, who has sort of given you a little bit of inspiration with your work.
Oh, actually, there's quite a few, but if one of them stands out in particular, but there are quite a few of these kids, and you realize how tough they are.
Sure.
One in particular had basically come into the hospital for complaining of chest pain, and actually eventually ended up passing out at the playground. Dad saw, he went to the usual daily trip to the playground. He was playing, and he fainted. He came in. He actually came in here. This was actually pretty early on when I first started to do pulmonary hypertension work. But he came in here, and because of he fainted, he was referred to the cardiology division to look for heart-related problems like arrhythmias, rhythm problems, or more commonly seen issues. And so he, as part of his evaluation, he got what's a good screening tool for many things, that he got an echocardiogram, which is essentially an ultrasound of the heart.
Okay.
And that demonstrated that he had pulmonary hypertension. And, I mean, he was all of about 4 years old. We started him on some pretty aggressive medications, and there are a variety of medications now available, but we started him on oral medications, and he perked right up. And, I mean, he couldn't wait, to get back out to the playground. And, I mean, I've seen him now. It's been about 4 or 5 years, and he continues on the medications, and now, he used to be on home oxygen. He used to be, fairly, limited, and he's kind of gotten to the point now he goes to school, he's off his oxygen.
Wow.
But he recognizes his limitations. If he doesn't feel good, he recognizes he needs to put his oxygen on. But he's really, just been very, very brave and very valiant about trying to lead a normal life. Being able to play with his friends and not let this disease restrict him. And he's done quite well. He's
how old
responded well to the medications, so in terms of that, it's not been an issue for taking care of him, because we haven't had to go up, but still, there's always that potential. The parents understand it's kind of like a time bomb. He's basically, eventually this is going to progress, and we're going to have to increase or become more aggressive with his medications.
Now, how old is that child?
He's now going on 9.
Wow. And, obviously, as you've been in the field for how many years have you been practicing now, doctor?
I've been practicing for 25 years.
Obviously there have been progressions in that time. There has to be a hopeful outlook, obviously, on the horizon about finding more treatable, things that can be done for people suffering from PH.
Well, to be honest with you, I started doing my PH work about 7 years ago.
Okay. And
most of it was because prior to that time, basically the mortality was 2 out of every 3 died within 3 to 5 years.
Wow.
For kids and adults, once they were diagnosed, regardless of what we were doing. The medicines and things there was not much available in terms of medical management. But back about 6-7 years ago, there all of a sudden became kind of a new group of medications that could be used by mouth to treat pulmonary hypertension. A lot of them are approved only for adults. So in the pediatric population, unfortunately, that kind of forces us to use medications that are considered off-label, which means that it's not technically FDA approved for pediatrics because there have been no studies. But unfortunately, in pediatrics, that's one of the things we find is that most medications we use are off-label because there's been no true testing done in the pediatric age group. But I think through a lot of experience across the country, we've developed kind of strategies in how to treat these patients, even though knowing that it's not been truly studied in pediatrics to this point. But there are a lot of medications that are given by mouth, a lot that are inhaled, and a lot that are now given intravenously that can be used to treat pulmonary hypertension.